you're going to need to be able to identify 5 different types of ulcers. The good news is that on the test, it's going to be based on the location and their history, and it's not going to be hard to spot which one it is. So first, I want to tell you which of the 5 ulcers you need to identify, talk about how you stage ulcers, and then go through each ulcer one at a time. So the ulcers we're going to be covering in this lecture are going to be compression, diabetic, arterial insufficiency, venous insufficiency, and the low yield, but good for a point or two, the Marjolin ulcer. And you'll see that these can be easily distinguished from one another. When you stage an ulcer, when we get the epidermis on top of the dermis, then you've got a fascial layer that separates the skin from the muscle and bone underneath. And for an ulcer, it doesn't really matter if you're talking about muscle or if you're talking about bone, because once you get through the fascia, it's the same stage. So you've got the epidermis, the dermis, the fascia, and then the deep tissue, muscle and bone. And it would be nice if it is lined up like this for stage 1 through 4, but they don't. Stage 1 is going to be a non-blanching erythema. You get a little red spot or ulceration that's painful on the skin, but it only goes into the epidermis and not down to the dermis. Stage 2 is epi and dermis are both penetrated. You're through the skin, but not to the fascia. Stage 3, you can see fascia, but not the tissue underneath. And stage 4, muscle and bone are exposed. And if you can see bone or probe bone, it's effectively osteomyelitis. So this is how you're going to communicate on the wards. Let's talk about what you need to find for the test. The first ulcer we're going to talk about is compression ulcers. And these are big no-nos. The pathology has to do with pressure points. If you lay still or sit in exactly the same spot, regardless of how soft that cushion that you're sitting on is, you are putting pressure on the skin. And if the skin has pressure on it from the surface and has pressure coming on it from the bone nearby, you're going to create an area of microvascular ischemia, and that tissue is going to die and you get an ulcer. So it's going to happen to people who are bedridden or wheelchair bound. The nursing home patients, quadriplegics, and paraplegics. In fact, if you identify that someone has an ulcer and they're living in a nursing home, it constitutes abuse. And the compression has to occur at a place where bone is really close to skin. That's going to be places like the back of the heels, the elbows, the shoulder blades, and then the sacrum. A sacral decubitus ulcer is a compression ulcer. The diagnosis is clinical. You need to do very little to diagnose it. And the treatment is also how you prevent it. The treatment is going to be to roll that person, to get them out of bed if possible or off the position that they're usually in, and then you can use cushions and air mattresses. But the key to compression ulcers is to never let them happen in the first place. And we're going to talk about this, how you treat that ulcer. Of course, if you have a wound, you're going to get wound care. And the only thing we know that actually works for wound care is going to be debridement of necrotic tissue, antibiotics when there's cellulitis, and keeping it clean. The ointments and the vitamins probably don't work, and hyperbarics might. So all of these ulcers should be considered wounds that you could treat with all this other stuff, But what I want you to learn is what is unique about the individual ulcers and how you treat them and prevent them. That's compression. Next is diabetic. And a diabetic ulcer is all about microvascular changes. You put in microvascular changes and a neuropathy together, patient gets in trouble. This is effectively a hybrid between compression and arterial. The vessels that get impacted the most are the ones that are the most distal. The nerves that go first are the most distal. So diabetics will present with neuropathy and a stocking glove fashion. They won't be able to feel their feet. So when they step on a nail, they won't know it. If their shoes are too tight, they don't feel the pain of it being crushed, and they end up with these ulcers. So if a patient is a diabetic, and they generally have to be a pretty bad one, right, to get the neuropathy, if you see ulcers on the heels or the balls of their feet, that is going to be a diabetic ulcer. If you touch it, they don't even know they got it. So, which is why diabetics need to look at their feet, and why you need to screen all diabetics, the monofilament test. This diagnosis is clinical. And yes, you do want to control the blood glucose and elevate the legs. But this is why patients get amputations. You get an ulcer, it doesn't heal, you end up with osteo, and the foot comes off. So it's best to prevent these by inspecting the feet and also making sure they've got good shoes. Ones that are loose. It won't cause compression. Arterial insufficiency ulcers are essentially peripheral vascular disease. They are macrovascular in nature. The patient is going to have peripheral vascular disease. We have a whole lecture on this in the subspecialty section, so I'll blow through it pretty quickly. Look for the hairless legs, the shiny and scaly skin, and absent pulses, particularly in the person who smokes a lot. This person who has arterial insufficiency is going to develop an ulcer at the site that is furthest from the vascular supply. So if you see ulcers at the tips of the toes, you have your diagnosis. They're arterial ulcers. Now, when you diagnose an arterial ulcer, if they don't already have peripheral vascular disease, you want to make that diagnosis. Again, more on that during that lecture. But you want to get an ankle brachial index, followed by an ultrasound with Doppler. This is an arterial ultrasound. And then an angiogram if you're going to fix it. And yes, you're going to do good wound care, but the way you can treat peripheral vascular disease is either with a stent or a bypass graft. And in general, you stent small lesions above the knee, bypass any lesion at the popliteal artery or any large length of lesion. That's the problem with getting blood in. There's also problems with getting blood out. That's venous stasis ulcers, where arterial ulcers with problem getting blood in, the venous ulcers are problem getting blood out. And the patient is going to have edema. And they'll have some condition that predisposes them to get that edema. CHF, cirrhosis, nephrotic syndrome, something that causes them to have chronic peripheral edema. What happens is they get stasis dermatitis. They actually get hyperpigmentation from deposition of hemosiderin. If you let it go on long enough, it's going to get indurated and woody. For whatever reason it is, if you see an ulcer on the medial malleolus, it is a venous stasis ulcer. The diagnosis is clinical, and you want to do things that get the fluid out of the leg. It's going to be compression stockings to help push the fluid up, elevate the legs, and give diuretics. Now, if you're able to fix the underlying condition, great. But to prevent that ulcer from getting worse or reforming, you have to get rid of that fluid, and you do that with compression stockings, elevation of the legs, and diuretics. The last one's low yield, and I include it because if you see it as 3 points, the Marjolin ulcer. This is actually squamous cell carcinoma. And the way it's going to present is either an ulcer with a sinus tract or one that breaks down and heals over and over and over. It'll have heaped up margins because it's a cancer. And this is the only one you actually want to biopsy. Notice we did not biopsy any of these ulcers. You biopsy the Marjolin ulcer to see the squamous cell carcinoma, and then you treat it with wide resection. All right, 5 ulcers you have to know. Let's hit on where they are and the special thing you need to know about each one. Compression ulcers are going to be in the sacral decubitus or anywhere there's pressure points. Prevent it from happening in the first place. Diabetics are going to have diabetes at the balls and heels of their feet. Look for the neuropathy, poorly controlled diabetes. Arterial ulcers are going to be at the tips of the toes. Work them up for peripheral vascular disease and reperfuse the tissue to save the limb. Venous ulcers, edema, hyperpigmentation, medial malleolus, get the fluid out. Marjolin ulcer, heaped up margins, breaks down and heals multiple times. Get a biopsy because that's cancer. That's ulcers.